Welcome everyone to this session of infectious disease epidemiology. I'm very pleased to introduce Dr. Jane Zucker, who is coming to us not only as the Assistant Commissioner of the Bureau of Immunizations at the New York City Department of Health and Mental Hygiene, and talk about what that's like in just a sec, but also as an assignee from the CDC to our health department. We're very lucky to have Jane and others assigned from CDC there. It really does help build our capacity at the front lines of many of the infectious disease threats and pandemics that the city faces first around the nation. So Dr. Zucker is both a New York City Health Department leadership member as well as a CDC assignee. In her role at CDC, she also serves as a liaison to the Advisory Committee on Immunization Practices, or ACIP. That's the committee that makes the public health recommendations on all of the COVID vaccines that you've been hearing about, and also monkeypox vaccines that have needed to be moved to the fore in an emergency phase to influence public health. And this is a very important committee that takes the decisions from FDA after they've decided that a vaccine is safe enough and effective enough to be authorized for emergency use. ACIP is the committee, the public health committee, that really takes it a step further and says, how are we going to recommend that this be deployed in routine practice for children and adults? And so I'm very pleased to have Jane come back to speak to the course. She has done so regularly for many years. She also brings a perspective to this part of infectious disease epidemiology and vaccine preventable diseases that is based in both a global health perspective, where she has worked on things like measles elimination around the world, and also the local public health perspective. Jane, thank you so much for being here. This is a favorite lecture every time of students in the infectious disease epidemiology course, and I'm going to turn it over to you. Please take it away.
Dennis, for that sweet introduction. It's my pleasure. I love giving this lecture, and I'm looking forward to when we can actually meet in person again. And because I also miss that sort of interaction with students when you're giving sort of recording presentations. Okay, so what I'm going to cover today is epidemiology, vaccine preventable diseases, and really try to give you a feel for the impact it has on public health. So we'll talk about burden of disease, strategies for using vaccine, and the examples I'll use to illustrate this is polio eradication initiative, measles, human papillomavirus vaccine programs, and then end about the global potential for vaccines. So I often start with this slide. I love it. It's the MMWR, published in 1999, and it looked at what were the 10 greatest public health achievements of the last century. And vaccines are number one. And I hope as we go through the talk, I'll convince you why that was. So we talk about the past with vaccines, but just thinking forward, these are Healthy People 2030 objectives. There are 16 related immunization objectives. And often I hear, well, didn't we control that, or didn't we take care of it with vaccines? But yet vaccines are still really critical to public health, again, as shown by them still being included in the Healthy People 2030 objectives. And so there are disease reduction targets. So we talk about wanting to reduce cases of rubella, congenital rubella, measles, other infections, hepatitis A, hepatitis B. We also look at coverage goals, what % of the population should be vaccinated. And then also something new for the 2030 goals were inclusion of immunization registries, which are databases of vaccines that are administered. And for those of you who may go on the health department website and you've seen how many COVID vaccines have been distributed and administered to various, whether it's by age group, race, ethnicity, and geography, it's all because we have this amazing immunization registry in the city. And so I'm glad, that has really made it into sort of national goals. So this table shows you diseases on the left-hand side here, and these are the sort of core childhood diseases, from the past. And so this is the 20th century, the annual morbidity. And these are 2019 reported cases. And if you look at these % decreases, everything is over 90%. you're hard pressed to tell me about other interventions that have had such, consistent real impact in terms of really reducing disease. So this is really, again, why vaccines have been a great public health achievement. And then these are sort of vaccines that have been introduced more recently. And these are, again, the diseases are here on the left, your pre-vaccine era morbidity, 2019 cases. And again, we're up over 80. So it's just amazing that 84% reduction in Hep A cases, 95% reduction in Hep B. There's almost no more H influenza B invasive disease. This was, killed 20,000 children prior to a vaccine being available. And then, sadly, we still have varicella deaths from people who aren't vaccinated. But again, almost, 100% reduction in varicella in children. So really big impact in terms of disease reduction from vaccines. Just look at New York City. These are our 2021 case counts. And this is by the diseases that we do surveillance for in the Bureau of Immunization. And I will say, because of the pandemic, we've never had such few cases. And even this is remarkable, no measles in 2021. But just to give you a flavor for public, from what impact and what local public health does, there were no measles cases, but yet we had 122 suspected cases reported to us, all of which had to be investigated to be sure that they weren't measles. And then this just shows you measles over time. And I said to 2021, so really this is the first time 2020 and 2021, no measles cases because there were no importations from overseas. But in 2018 and 19, we had a large outbreak of measles, and I'll talk about that later. This was the largest outbreak since the 1990s and since measles elimination. And in fact, we almost lost our elimination status. If there had been continued transmission for 12 months, we would have lost it. And we actually ended the outbreak at 11 months. But there have been other measles outbreaks sort of that are shown in this table, every, 2014, 2013. Also 2011. So I think all of this shows vaccines are a good investment. There have been a number of cost effectiveness studies that have been done. And this is an older one, and they have updated it, but it sort of makes the point very well that just that routine childhood immunization series of these core vaccines listed on the slide was actually cost savings. We're talking about 20 million cases prevented and 42,000 deaths. And so it's not only savings, we're talking about almost 14 billion in direct costs, but when you add in all the societal costs, almost $70 billion. And so this, showing these benefits were really critical. So it's why vaccines are actually covered under the Affordable Care Act, because there's an evidence base and there's, for one, the impact of vaccines and also, the cost benefit of it, including them as part of required insurance coverage. So this is what the schedule looked like in 1985. There were 3 vaccines. We vaccinated against 7 different diseases. And this is the 2022 schedule. This is put out by the Advisory Committee on Immunization Practices, ACIP, which Dennis mentioned at the beginning. But this is what the current schedule looks like. And there are 16 vaccines listed, and it's very complicated. You have your vaccines on the left-hand side of this table, and then the age groups that it's recommended for over the top. And then you have the different color codings, or whether a vaccine is routinely recommended. Maybe like purple, for example, is recommended only for high-risk groups. And then it also would highlight if there's contraindications. So it's just a lot more complicated than it had been. And so we actually program all this into the registry and provide decision support for the vaccinating provider community, so that try to make it a little bit easier to make sure that children are getting their shots on time. So I'm just going to show a couple of screenshots of the schedule, and I only want to give you a flavor for how complicated. So this table is sort of vaccines recommended by age, and then they have a catch-up schedule. These are for children who fall behind. And then there's another table which tells you the vaccine by disease, which is actually really quite helpful for providers. So, for example, you can see if a child has diabetes, if there are any additional vaccine recommendations. And then there are 4 pages of footnotes. So again, just a flavor of the complexity. And they also go this, there's another appendix. This table tells you about contraindications and who you shouldn't give a vaccine to. So each of those footnotes actually has a full ACIP sort of recommendation, often a 40-page publication that goes through all the data that supports that recommendation. So a lot of complexity, and I would say that's what we sort of do in the Bureau, our job to sort of know all this. And, one of the things we do, which is actually quite enjoyable, is we actually do have a hotline for providers to ask us questions about the schedule and also take calls from the public. So there's also, so that was the pediatric schedule, but there's an adult schedule which follows the same pattern. Again, vaccines by age group and then by condition. Again, really, I think helpful. And these, first do set the national standards. So, for example, I just gave a recent talk about vaccines for persons who are living with AIDS, and it's very easy to sort of focus on that column that really provides those recommendations, and it's sort of helpful, to be able to focus providers on, their particular populations. So when we talk about approaches to disease control, how do we use vaccines? So people talk about eradication. That's when there's complete interruption of transmission and there's no risk of infection. Elimination is when you'll interrupt transmission in a given geographic area. And then control is you're reducing transmission. You can't sort of break that cycle of transmission, but you really want to reduce disease and try to prevent infection through vaccines and then treatment if necessary. So smallpox is the one human vaccine, one human infection that has been eradicated. And, smallpox really was around for a long time. And we're talking about 300 to 500 million deaths. Really, the case fatality rate was 30 to 35%, much higher in children. And so this vaccine really had huge sort of impact on, just global mortality, the morbidity from smallpox. And there was this huge investment, in eradication, and that was certified in 1979. And I think, so a few words about smallpox. This slide, I put in the last smallpox outbreak in New York City was 1947. This is a health department clinic. And these are people lining up for smallpox vaccine. So, before COVID, I would say, people are scared about smallpox and they want to be vaccinated. And then COVID initially, we had long lines and people trying to get appointments. And, it's an interesting balance to, people who may not want to be vaccinated now. But again, this just gives a good sort of historical perspective. When you're afraid of an infection, people, will certainly, stand up and wait a long time for their vaccination. And so this is the vaccine that was used. It was called Dryvax. But what was really elegant is this is a bifurcated needle, and you put this end of the needle into the vaccine vial, and through capillary action, it sort of in this portion brings up the right amount of vaccine. And you basically use that to sort of break the dermis and sort of prick the skin to inoculate people with the vaccine. And this was it's incredibly simple and elegant, and it was really necessary because it was a way you were able to bring vaccines throughout the whole world. You didn't have to worry about people knowing how to give injections in terms of trained healthcare. You didn't have the same challenges with disposals of needles, although these needed to be disposed of properly and sterilized. You didn't have all of the other sort of needle and syringes. And you can use, lay people or non-medical people to help with the vaccination program, and it was easy to carry. Because, the last case was in Somalia, last wild smallpox case, and you can imagine you need to fan out, and this is what the eradication program did. It fanned out to, through every country and every village, to make sure that, people had, were vaccinated, in order to achieve eradication. So smallpox is the gold standard, and these are really the criteria. There is interest in what other diseases can be eradicated. And you really need to know whether, there has a human host. You need to recognize, readily diagnose the disease. Smallpox, people were able, very recognizable. There's no subclinical disease and no carrier state. There were clear socioeconomic benefits. It was biologically plausible. This was proven, through the initial vaccination effort. And then there was a lot of field experience, which was gained, and they had the successful vaccine. And, they really had to build up the infrastructure for smallpox eradication. And that infrastructure is what later became the expanded program on immunizations to really allow, or provide immunization programs in all countries. And of course, as with everything, and certainly as we've seen how important that political will is to achieve, more recently with our vaccine campaigns, but was really critical in terms of the global support to eradicate smallpox. So, the next disease that they're hoping to eradicate is polio. And polio is an enterovirus. And there's actually 3 types of polio. So type 1, 2, and 3. So you have to eradicate each type. Type 1 is causing most of the outbreaks now. It's the only one left. The last wild type 2 was isolated in 1999. And the last type 3 was in 2012, and those have been certified as eradicated. And polio is highly contagious and will infect, essentially everyone, who's susceptible in a given area. And it is so, like most enteroviruses, transmission is fecal oral. Time from infection to onset of paralysis is 10 to 21 days. Because the virus is excreted in the stool, you get very rapid spread. Especially if you're, in a low resource country where there may be poor sanitation, and you do have most excretion of virus before paralysis. So that may be before the case is recognized. So polio does meet some of the criteria for eradication. It only infects humans. There's no animal reservoir. It won't survive long in the environment. And there's no long-term carrier state, although there are some exceptions with some severely immunocompromised persons who have actually shed virus for years, but those are sort of the exception. So what happens is you ingest the virus and it replicates in your GI tract. You get a viremia, and then the virus has the predilection for these specific motor neurons of your anterior horn cells. So this is a cross-section of what your sort of spinal column. And it replicates in those motor neurons and basically kills the cells. So you're no longer innervating your muscle. And that's where you get that flaccid paralysis. The cells are destroyed. So the muscle is no longer innervated. And if it involves the brainstem, it could affect, the sort of control of your diaphragm and breathing. And that's what would be called bulbar paralysis. And that's what caused a lot of the deaths that we're seeing from polio. So the challenge with polio is that 3/4 of the cases are asymptomatic. So you wouldn't recognize them. These are just infections. And another quarter have a minor illness. So another sort of, like any viral illness, maybe fever, aches and pains, nothing that would bring people to medical attention. 4% will get aseptic meningitis. So that's inflammation of the lining of the brain. And less than 1%, it's like 1 in 200 will get paralytic poliomyelitis. And it's those paralyzed cases that are really used for surveillance. So we have 2 vaccines. There's inactivated vaccine. This is a Salk vaccine. It's a trivalent. So the vaccines are against type 1, 2, and 3, right? You need immunity to all 3 types. And it does produce protective antibodies, and this is inactivated, so it doesn't replicate, so you have no risk of getting paralyzed from the vaccine. As far as, this is what we use in the US, it's been the only vaccine we've used since 2000. But the disadvantages from the perspective of a global campaign is that it does require an injection by a trained healthcare worker. And again, from a global perspective, this is a higher cost vaccine than the oral polio vaccine. And what's interesting is you do get protective antibodies, but because it's an injection, you don't actually get any immunity in your gut. So you can still actually sort of get an infection with polio and excrete poliovirus, although not be at risk for paralysis. And the second vaccine was the Sabin oral polio vaccine. Again, and this is just, I have some pictures of it. These are just drops that you would put in a child's mouth. It's oral, very easy to administer. It does give gut immunity. You actually excrete the virus, the vaccine virus, so you actually sort of immunize other people in the community. And it's easy, because it's easy to administer. Again, you can sort of use laypersons. A lot of these large vaccination activities use, for example, teachers, other members of the trusted members of the community, and it's a much cheaper vaccine. These are sort of the UNICEF prices here, but 11 to 18 cents a dose. But the problem with this vaccine is because it's live attenuated, through the replication process, it can revert to neurovirulence and actually cause what's called vaccine-associated paralytic polio. And that risk is sort of 1 in 3 million. And, once polio was eliminated from the US, soon after we had switched to IPV, because that risk-benefit balance was no longer in favor of OPV, at least for the US, and in order to avoid, there were more cases of vaccine-associated paralytic polio than there were of wild-type polio, and that's when we had switched over to IPV. So thinking about whether eradication of polio is feasible, right, it does check some of those boxes. With no animal vector, we have an effective vaccine, no carrier state, it doesn't survive in the environment. But the challenges are really there are a lot of infections which just aren't recognized, and the flaccid paralysis can be similar to other infections, and so there's a differential diagnosis, and you need a real confirmation component of your surveillance to know that what you're seeing is really a case of acute flaccid paralysis. So this is just the sort of overview of the global polio eradication program. It was launched in 1988. And then this is recent data from the WHO website, and there are only 2 countries now that are still endemic. That's Afghanistan and Pakistan. So if you look at, how many countries were endemic when we started in the upper left-hand side of the slide, they estimated there were about 35,000 cases, although they thought at best they were only recognizing about 10%. And so again, amazing, so far this year, there have only been 27 cases. And, what's unfortunate, Mozambique is here as an outbreak country. There was an introduction of a wild poliovirus type 2 that was linked back to Pakistan. And there have been 6 cases now identified in Mozambique. And so, as the global program goes on and as there's still transmission, all of these importations continue to be a risk. Last year, there was an importation into Malawi. So again, importance of sort of maintaining strong immunization programs for, to prevent importations. The polio program works through these national immunization days. So in addition to routine vaccination, you give children extra supplemental doses of OPV. And then, it's the backbone of any sort of public health program. You need to have surveillance. Right, you need to know, the scope of the problem, the epidemiology, and you need to be able to track your interventions. And then they also do these, what they were calling sort of mopping up immunization. So if there was a case identified within particular regions, to do special vaccination campaigns. So this gives you a sense of just, again, the sort of scale of this program. This is from last year. There were 94 supplemental immunization events in 30 countries. And you can see how many doses of vaccine were given. They give, and this is a sort of, in order to prevent some of the wild type polio from reverting, the vaccine strains from sort of reverting to neurovirulence, because there was no more type 2, they actually removed it from the trivalent vaccine. It was trivalent OPV, which was against type 1, 2, and 3. And they switched over to just bivalent to, again, maintain population immunity against what were still circulating strains. They did introduce IPV globally in 2016 with the hope of being able to withdraw use of oral polio vaccine. That's been I would say, a much slower process. But they also use sort of other monovalent products, such as a monovalent OPV2. And I'll talk about some outbreaks that are related to sort of vaccine-derived polio strains that they've used that vaccine for. And then they've also started reusing the trivalent vaccine. For example, in Afghanistan and Pakistan, not only do they have their wild type 1 virus, but there's also the vaccine-derived poliovirus type 2. So they've gone back to using trivalent vaccine in those cases. So just for a word about surveillance, again, you want to show the absence of wild polioviruses. There are certification standards to know that your surveillance is adequate enough to be sure there's no wild type polio circulating, and then also you're using your surveillance to guide your immunization activities. And I will say, part of these strategies, right, it's finding, reporting acute flaccid paralysis cases. You have to actually look at stool, you try to recover the virus, you do genetic analysis and mapping of the viruses. Some really interesting work about just how polio virus sort of replicates and the sort of genetic changes and genetic clock to the virus. But all of this mapping is why, how they know that the cases in Mozambique were related to a virus that was circulating in Pakistan. And then environmental surveillance has been an important part of the global program because you may find the virus in wastewater before you actually find a case. And that also, may trigger vaccination activities to prevent a case of paralytic polio. And I'll talk a bit more about that. So these are just slides. I was actually assigned to UNICEF for 4 years, overseeing the global polio eradication program. And the whole idea is that you go where people are. So this is from Asia. This is actually from Cambodia. If people live, on the water and in houseboats, and you vaccinate, where they are, and you go house to house or boat to boat with vaccine. This is actually the Tonle Sap in northern Cambodia, but they didn't understand why they were doing all these vaccination activities, and they weren't interrupting transmission. And someone was flying into the area, and they realized how many people were living on the water and hadn't been included in their supplemental vaccination campaigns. And that's why they then went and did the boat-to-boat vaccination, to ensure to capture that population. So here's just a picture from India where they're investigating a case of polio. And this is a vaccine carrier, but you use it for stool because, we talk about you have to get polio vaccine out to every community, no matter how rural or far flung. And so you have these carriers, but when you're doing an investigation of a case of acute flaccid paralysis, you have to go out to where the case is and get a stool specimen and bring it back the same way and maintain the cold chain so that the virus can be isolated. So, the program, global polio program, has been through, I would say, ups and downs. It's been challenging. They originally had a goal of the year 2000. And so, a lot of assessments and reviews for why there's persistent transmission and why, while having an effective vaccine, they've been unable to interrupt transmission in all countries. And one of the big things is just under vaccination, low routine coverage. Global coverage for 3 doses of polio vaccine was only 83% in 2020. The year before it was 89%, and we know that coverage dropped further during the pandemic. So Afghanistan and Pakistan, with the 2 endemic countries, routine coverage is only 73% and 83% respectively. That's really too low to interrupt transmission. You really need to be over 90%. And then I had sort of alluded to this earlier, but this emergence of these vaccine-derived viruses. And I'll talk more about that on the next slide. And also vaccine failure. The vaccines have to be kept cold. And so if you break that cold chain, you may have vaccines that are no longer potent. Poor implementation of strategies. I gave an older example from Cambodia, but if you're missing large segment of your population and you're not vaccinating them, you're not going to be able to interrupt transmission. And then the program has gone on for quite a while, and so it's gone through periods of insufficient funding and also loss of global momentum. because these national immunization days and vaccine campaigns are really quite labor intensive. So they really are at this critical juncture. So back in 2019, and so this again pre-pandemic, there was actually an increase in wild polio cases in Pakistan and Afghanistan. That's really has continued. There are fewer cases now in 2022, but transmission has continued. And I mentioned the outbreak in Mozambique, and so that further risks the program by introducing wild polio virus into sub-Saharan Africa, where vaccine coverage is also low. And then there's been this increase in these vaccine-derived polioviruses. I mentioned, that they took, so there's no type 2, and they removed that strain from the vaccine. And what had happened was that there was really that the vaccine strain, as it replicated and became neurovirulent, was circulating at very low levels. And without that continued immunity from vaccination, a lot of outbreaks have sort of popped up in many different countries. And this year alone, there have been 19 detections. That's, some countries have had more than one detection, but 359 cases. So I told you we had 27 polio cases, wild polio cases, but 359 of these vaccine-derived polioviruses. So it really is a big setback, and really led to the reintroduction of that monovalent type 2 vaccine. And of course, the US is now one of those countries as well, that has one of these BDPV outbreaks. And many of the polio eradication activities did get suspended because of COVID. And I showed you, these large numbers of vaccines that were administered last year, but, pre-pandemic, it was really much higher. So of course, it's been in the news. There was a case of paralytic polio, which was identified in Rockland County in north of New York City. So these are just, I know we had a press release. We found wastewater, poliovirus in the wastewater in New York City. And then the MMWR article that describes this case, and the response efforts is given here. But when they had when this case was identified in Rockland, because there's a lot of movement of people from the city to Rockland, we actually started wastewater monitoring to see whether or not we could detect poliovirus in the city. And of course we have, and just recently there was actually a statement would have come out yesterday that we've been able to link viruses that we found in the city back to this Rockland case. So this is also a vaccine-derived poliovirus type 2, similar to what's been causing a lot of outbreaks around the world. And so now that there's evidence for community transmission, because there have been several counties upstate which have been positive, it actually triggers additional sort of notifications from CDC, and it changes some of the international health regulations about vaccination. But whatever, the way you interrupt polio transmission is through vaccination. And, toward that end, we did look at polio coverage in the city. Overall, these are for kids 6 months to 5 years of age. Coverage is 86%. If we looked at least one dose, we're well over 95%. But there are neighborhoods, the lighter color here, which do have lower coverage that we're worried about, that we've been very focused on trying to increase vaccination. This does correspond with the sewer sheds where we've identified the sort of vaccine-derived poliovirus isolates. And I think through our efforts, citywide, we've seen a 9% increase in vaccination. And then in some of these neighborhoods, we've actually seen a 25% increase in number of IPV vaccine doses that have been administered. So I think that that's a great success. And many of those children who are getting vaccinated now are getting, they're being vaccinated for the first time. They were on a delayed schedule, communities that were delaying vaccination. And so it's really important, that we're now getting these kids protected. If there's a paralytic polio case in the city, it really is just, I think, a failure of public health. And it's just a failure of the medical community in terms of intervening and really protecting kids with vaccination. So let me turn to talking about elimination. And there are measles elimination goals for all the WHO regions. And only the Americas viruses were declared, did meet the standard for measles elimination, but transmission has been reestablished. Again, this really happened with collapse of the Venezuelan government and large measles outbreaks and exportations really to other countries in Central and South America. So measles is a different kind of a virus. It's a paramyxovirus. It's an RNA virus. Measles is a bit simpler. It's one antigenic type, and the primary infection is in the respiratory tract. Incubation period is 7 to 21 days, and people are infectious 4 days before rash onset to 4 days after. So that 4 days before is often where we see a lot of our exposures before people know they have measles. So, classic measles is characterized by fever. It's a maculopapular rash. It sort of starts sort of hairline your face and sort of spreads down your trunk and then goes out toward your hands and feet. About a third of cases will have complications. So otitis media is ear infections, diarrhea, pneumonia. You can also have central nervous system complications. And deaths in the US are rare. If you're in a low resource country and you have a lot of malnourished children, the case fatality rate can be as high as 25%. And sort of globally, it is a leading cause of blindness because you can actually get corneal lesions in particular. So measles is highly contagious, and its spread is through large respiratory droplets. There is also airborne transmission that has been very well documented. So there's been a vaccine in the US since 1963, and since then it's undergone, different strains have been used, and our current vaccine was licensed in 1968. We give it as measles combined with mumps and rubella, so that's MMR vaccine. And we give children 2 doses. We give them their first dose at 12 to 15 months of age, and then the second at 4 to 6 years. And the children do need 2 doses of MMR to go to school, and there are vaccine requirements for daycare. So this just shows you cases and on the y-axis, and then just by decade on the x-axis, and you can see vaccine license, just really sharp drop in measles cases. But then I mentioned our outbreak, and this was 2018-19. It was 649 cases. It had started in really end of September 2018, and really didn't end until July. This was the last date of rash onset, and then we waited 2 incubation periods before we called the outbreak over. And we really did see cases, not cases in the Bronx, but really this outbreak was centered in Williamsburg, which is in red, and then Brooklyn, Borough Park mostly, which is the sort of orange, and sort of other parts of Brooklyn are represented with some cases in Staten Island. And just wanted to point out in terms of the epi, we're really looking at, almost half of these kids were 1 to 4 years of age in the outbreak. And these are children who, had they been vaccinated on time, would likely not have gotten measles. And then, of all of our cases, 3/4 of them did not have any vaccine. So, most of these cases, again, would have been preventable. We give vaccine at a year. So only kids only the cases in infants wouldn't have been prevented because we wouldn't have vaccinated them. But we did actually lower the vaccination age to 6 months in terms of trying to interrupt transmission. So the median age was 3 years, but it was really quite a range from 1 month to 70 years. And this is just a slide summarizing the complications we saw. And, I included this just as a reminder that measles is not benign. And even though we may be in a well-resourced country, with not everyone has access to medical care, but at least much greater access in other places, we still were looking at 8% of cases that needed hospitalization, 20 people who were in the intensive care unit. And, the complications that I mentioned before, we saw, all the common ones with pneumonia, otitis media, and diarrhea. And fortunately, we had no deaths. Unfortunately, we had no cases of encephalitis. And this is, again, this is the bread and butter public health, infectious disease public health. What are your outbreak control measures? What did we do to interrupt transmission? We had to, identify and notify exposed contacts. For measles, you can give post-exposure prophylaxis, but you have to give it within 3 days. So there's a lot of, speed and, immediate response that's needed. Provider communication, we had a lot of targeted communication to communities that were affected, as well as providers citywide. Lots of work in terms of press releases, media interviews, articles, print ads, social media. We did a lot of work recalling unvaccinated patients. So this is sort of an evidence-based strategy, and for providers to sort of use their EMR, or we can use the immunization registry to identify children in a practice who haven't gotten their MMR vaccine. And either providers can call families to make appointments, they can send letters, or we have text messaging service through the registry to sort of let these families know that their children need to be vaccinated. And then children were excluded from daycare or school in the affected neighborhoods. And then also a lot of community engagement work, which is really essential. And again, just a flavor of what it means to do public health. We had over 20,000 exposed contacts. And these are identified contacts, not the ones we couldn't. These are sort of named contacts. We had, exposure in healthcare facilities, exposures in schools and daycare that really helped fuel the outbreak. We identified over 100 chains of transmission in this outbreak. There were multiple importations. 2019, there were large increase of measles just globally. And so we saw more importations. There was vaccine hesitancy. There was a lot of vaccine misinformation, not dissimilar to what we talk about around COVID vaccines. And we also had parents who were not bringing their children for medical care or providing exposure information. So we couldn't do, intervene with contacts and offer vaccine, for example. And a lot of cases were identified retrospectively because the parent didn't bring the child in to be seen by the pediatrician. We knew they were unvaccinated, but then the parent later got serology, and that showed that the child had gotten measles, was now immune. And this was done often so the child can return to daycare or school. So for the global situation, I mentioned that 2019, there was just a large outbreak. And this is, global increase in cases. There were over 500,000 cases. 2018, there were over 140,000 deaths. Again, horrible. There are global goals. We're looking before there were a lot of attention on measles. We were looking at 871,000 estimated deaths, and we had reduced that to about 110,000 deaths in 2017. So having 140,000 deaths in 2018, it's really, again, a real step back, in the global program. And again, a lot of that really because of under vaccination and vaccine misinformation. So this is sort of where we are now with measles. So here's the large increases that we saw in 2019. So this is 541,000 cases. And then, cases dropped. And again, we had the pandemic and less travel, social distancing, less transmission. But as things have been opening up, less restrictions, we are seeing an increase in 2022, again, up to almost 75,000 cases. And there have, been alarm bells, about this increase. And a lot of the, impacted countries are really in sub-Saharan Africa, as well as in Middle East and in South Asia. And, so I did take out another map that actually showed vaccination coverage. And, these are countries, if I overlay that with vaccination coverage, these are countries that all have low vaccination rates. And we know both in the US, in New York City, and globally that because of the pandemic, vaccination coverage sort of, dropped everywhere. And that is sort of, putting these children at risk. And what we're seeing are now, this increase in measles again. So I want to turn to talking about HPV for which is an example of control. So it's a non-enveloped double-stranded DNA virus, so a different type of virus. And it is the most common sexually transmitted infection in the US. So an estimated 79 million people are infected, and about 14 million new cases every year. And it's common among adolescents and young adults. And this was an HPV prevalence study that was done pre-vaccine. And basically, so, soon after, starting sexual activity is when people get exposed to HPV. But you can see the sort of prevalence, highest among, sort of younger adults and teens, and sort of drops off with age. And that was in women, but there would be a similar graph with men with sort of a high sort of background prevalence of HPV. So this is, we're worried about HPV because of the associated cancers, and we're looking at over 46,000 cases attributed to HPV. And in females, it's over 25,000 cases, almost half of which are cervical cancer. And then in males, it's over 20,000 cases, and 82% of those are oropharyngeal cancer. And there's been an increase in HPV-associated oropharyngeal cancer in recent years. So we're talking about a big burden of disease. So we use Gardasil 9, which is a non-valent HPV, so it protects against 9 types of the HPV virus. We give vaccine routinely at 11 to 12 years of age. We can give vaccine as early as 9. And we give 2 doses if a child starts before their 15th birthday. Because of how immunogenic this vaccine is, it's 3 doses after 15. And routine vaccination is recommended for anyone through, really, it's age 26 now for both males and females. And, and regardless of whether they're high risk. And the vaccine is licensed through age 45, and that's really based on individual clinical decision making. And what that means is really, again, if people are have one sexual partner, they're not going to be exposed to new HPV types. If people are, have new sexual contacts, then they are at risk, and that's a group, where you may recommend HPV vaccine, after age 27. So this just shows you how we're doing in the city. This is by quarter, and we look at HPV coverage among 13-year-olds, right? You should be vaccinated at 11 to 12, and we're trying to look at on-time vaccination. And this is, again, pandemic, we sort of fell a bit, not as much as we've fallen for sort of younger age vaccination, but about 74% of 13-year-olds in the city have gotten at least 1 dose of vaccine, and 47% have completed the 2-dose series. And there's a lot of evidence which has accumulated about the impact of this vaccine. In Australia, when the vaccine, early availability, they did these national school-wide vaccination programs, and they were vaccinating basically only females in the program. And they saw a 77% reduction in the vaccine type HPV prevalence in females 18 to 24, and 93% reduction in genital warts. But what was really interesting and sort of evidence of herd immunity is that they saw an 82% decline in men as well in terms of for genital warts. So again, men were being protected through herd immunity. Women, the females were no longer infected and passing it on. So this was really this was the first sort of demonstration of the degree of herd immunity that they were able to achieve with the vaccine. And then that same NHANE study, that the slide I showed with prevalence of HPV, they repeated the study comparing prevalence of the HPV types that are in the vaccine. And this was only, 4 years into the vaccine, when vaccine was available, and they compared it to pre-vaccine. And you're talking about a 64% reduction in the 4 HPV types, which were in the original vaccine, and a 34% decrease among sort of women who were 20 to 24. And HPV prevalence was 2% among vaccinated women compared to 17% among unvaccinated. And then a recent article in The Lancet actually looked at the HPV program in the UK, which also focused on vaccinating, females at when they were 12 and 13, and they've actually seen, and now it's been gone on for enough years, they've actually seen an 87% decline in cervical cancers, which is again pretty remarkable. And they're talking about sort of eliminating that risk of cervical cancer. And what's exciting to me is all those 13-year-olds, all these teens who we vaccinated, we're really looking at the future of sort of, again, eliminating the HPV complications and being able, to sort of eliminate that risk of cervical cancer. So I want to end on an international perspective. We have, the HPV vaccine campaign here, but really, if you look at the burden of HPV cancers and cervical cancer, it's much higher, in other countries. And this is, from a New England Journal paper that this was in the pre-vaccine era, but really shows you the incidence rates of cervical cancer per 100,000. And just that the countries at the time that were introducing HPV vaccine were those with the lowest incidence. And the challenge was, how do we get vaccine to other countries, that need it, have high incidence of cervical cancer? And how do you finance it? Because it is an expensive vaccine, and you need sustainable funding to maintain a program. So some of the barriers to introducing new vaccines, often, countries may not know what the burden of disease is, and in their particular country, the concern about cost, sustainability, limited infrastructure, whether the healthcare system and public health system could absorb additional vaccines. At the earlier point, they were worried about vaccine supply, and then that whole balance of how do you prioritize interventions. So in January 2020, this Global Alliance for Vaccines and Immunization was launched with partnerships and external funding to really help introduce these new vaccines to low resource countries. And really, it's amazing. HPV vaccine has now been introduced into lots of countries, and lots of countries in sub-Saharan Africa. Rwanda has probably done the most amazing job where they've been vaccinating school-age girls, and they're actually on track to sort of eliminate cervical cancer in that country. So lots of recent success. So I'll end with talking about vaccine challenges. And again, I wanted us to sort of stay away from that COVID issue, but it's a lot of the same issues that we saw play out with COVID in terms of, if we have a good vaccine, if we have a disease that's so deadly, why aren't people being vaccinated? And, people do worry about vaccine safety, right? It's all part of the clinical trials. There's a vaccine safety surveillance system in the US, but vaccines are medications and they do have side effects. Sometimes there's known risks of certain adverse events. These may be people we screen so we don't vaccinate them. And then again, we have this surveillance system to really detect whether or not there might be a risk. And a good example would be the identification of the risk of myopericarditis with the mRNA COVID vaccines that were really identified through this surveillance system. So if vaccines are so good, which I hope I've convinced you, why are we only hearing bad stuff? And, controversy sells. There are a lot of sort of high profile, stars, talking about, what vaccines may have done to their child, whether or not it was actually causal. There was an older clip, but it was Jenny McCarthy who was talking, as a mother about her son and knowing, just the emotion of, what happened to her child. And then it was sort of compared with talking heads from public health, giving you the sort of science. And, the science couldn't really compete with that emotion. Also, preventive medicine isn't glamorous. We can't count cases we didn't, we prevented. And, we are victims of our own success, whereas examples where people feared smallpox, where people don't see measles and they don't appreciate, how severe infection can be and what the complications are. And so they're not really seen as much of a threat anymore. And the adverse events are sort of seen as being more serious than the infection. And then in 1988, this was a famous Wakefield study that was published in The Lancet that imply this link between MMR and autism. And it sort of was almost taken out of context with where they had studied children who were said to have sort of regressive developmental delay. So they were fine, and then they got vaccinated and they worsened and lost major milestones. But what really happened was that the whole study was actually a sham, and it was all designed, for at least Wakefield and lawyers working with in terms of setting them up to sue the vaccine manufacturers. And so, since then, there have been a lot of studies which have, shown the safety of the MMR vaccine. And a lot of findings came out that Wakefield had actually, made up some of the stories in they weren't true cases that were included in his study. And so, and it wasn't reproducible. And then, at least 10 of the original authors had retracted. But even though this was a, not a well-done study, falsified data, later retracted, it still had really significant impact. And this is vaccination data from the UK. And this is again, earlier 2004, 5-6 range. This is DTP vaccine, but you can see what happened to MMR vaccination. It went as low, as 80%. And they actually had established measles transmission again in London, and when you have, dropping immunization rates, you do, these diseases come back, even though you've interrupted transmission. And this was at the same time the UK had this large mumps outbreak of, over 50,000 cases, again, associated with a drop in MMR coverage. And what we're seeing now is with, where we have pockets of lower vaccination in New York City, in the US, New York State, that we're seeing this now introduction of these vaccine-derived poliovirus. So it's sort of the ongoing story, and we're never done with vaccination. We need to really, we're in it for the long haul and really need to maintain high coverage. So just a word ending on a upbeat note about future potential for vaccine development. This report, which was published in 10 years ago and hasn't been updated, but has a lot of really exciting information in there about vaccines that are being developed, whether or not to help, ideas about whether or not you can prevent Alzheimer's vaccine, whether you can prevent addiction or treat people by having a vaccine that may block, let's say, the nicotine receptor. So people, will, to help with smoking cessation. There's lots of sort of vaccines now that are sort of part of cancer programs. Vaccines that you can sort of develop to target specific proteins on the surface of cancers, and also looking at sort of developing, vaccines to help prevent type 2 diabetes. So lots of exciting work that is going on with vaccines. If you went to clinicaltrials.gov, you'll actually see and look at the vaccine trials. There's just a lot of exciting work around other pathogens, that cause significant morbidity, mortality. There's some elusive vaccines. They've been looking, work on an HIV vaccine, for over 20 years. But again, as people learn more about immunology, as we have new delivery systems, new platforms like the mRNA technology, opens up new opportunities for vaccine development. So I've included some references, and I'll end. So I love this. This is Kofi Annan, who was the UN Secretary General many years ago. But these are all these children getting vaccine, and you can just see how, this is the oral polio vaccine and how easy it is to sort of administer the drops. And so thank you. And I hope, wish you a great discussion, part of the course. And thank you very much for having me.
Thanks so much, Jane. That was like such a great overview, and making the strong case with really excellent examples of why vaccines are such an important part of public health. And yeah, I'm always struck by the numbers. Like we for example, have, close to 1 million HIV related deaths every year. And the fact that, it may be that one day there'll be a vaccine. I mean, of course we have treatments, right? But maybe that one day we get a vaccine, and then we see some of these same improvements in the mortality rate that you've seen for some of these other vaccine preventable diseases. And of course, there's also news about a malaria vaccine, or a couple of malaria vaccines in the pipeline,
Right.
which could have the same, global effect. It's all very exciting, and I hope it holds promise.
Right. Well, I think that's a challenge for me. I can talk about so many, impact of pneumococcal vaccines globally in children that were saved, COVID campaign, monkeypox. It's been, for someone in immunization, it's certainly been an exciting few years.
Well, and I think it is a cornerstone of public health.
Right.
I mean, unlike medicine, where you're doing a lot of treatment of people who are already ill or are sick, this really is about prevention in so many ways. And that's a big part of what public health is about too. Can I ask you just a couple of questions to go back to a few points in your talk? So the polio case in Rockland County. So just talking about what we know about the natural history of wild type polio, 1 in 200 people that are infected develop flaccid paralysis. And so when we heard about that one case in Rockland County of paralytic polio, the first thing that went into many of our minds was, oh, that means that there could be 200 other cases out there. And I know that's true for wild type polio. So one case of flaccid paralysis that's polio caused by polio means there's a lot more polio out there than that one case would suggest. Does it mean the same thing for these vaccine-derived cases?
Yeah, so for this type 2, it's probably about 1 in 2,000 in terms of one paralytic case. But, I think honestly, we've all been like holding our breath, and we're amazed we haven't seen a second paralytic case. Given what the size of the community, the repeated detection of these viruses in the wastewater, we know it's circulating. But, it's great, but again, I keep waiting for the other shoe to drop. It's why I feel such urgency with getting children vaccinated. They may get infected. And that's the other thing is like if you have an IPV, you may have some protection from paralysis, but you can still excrete this vaccine-derived, the virus, because it still is replicating. So whether that's sort of the balance, like there's enough, sort of community level protection that we're not seeing a lot of cases because of IPV. But again, it's why that focus on this youngest kids. And I think also, a real difference is the sanitation is sort of different in the US in terms of people having access to clean water, reducing the risk of exposure, which has probably reduced the risk as well. Yeah,
great points. And congratulations on getting the vaccination coverage up in those neighborhoods where it was low. That's just great progress. Okay, HPV, the herd immunity data you showed was really compelling. Right now, I think that it's primarily a vaccine that's recommended for girls and adolescent girls and young women. And does the herd immunity effect suggest that boys should be vaccinated as well? And
we do routinely vaccinate. So if I didn't make that clear, so our routine program in the US is actually girls and boys. It's irrespective.
Okay.
So, right.
Great. Initially, though,
that was actually a big debate at the time, Dennis, because look at Australia. They only vaccinated girls, and look at this big impact. They were protecting boys. Should we, what should the US program look like? And so, I think with all sort of modeling and discussions, the decision, we actually went forward first with girls, and then boys were added later into the program, like a few years after that. So, and then there were also these like funky differences where we were vaccinating women through 26 and only men through 21. It wasn't as cost effective to vaccinate men after that age. If they were going to be infected, they were already infected. But I think there were a lot of compelling reasons in to be protected as a male, you need to, from a woman being vaccinated, you need to be having sex with women. And so, you know, there's really a lot of serious HPV disease in men who have sex with men, people who are living with HIV. And so there was really a lot of compelling reasons to sort of be vaccinating, you know, both boys and girls. And it's why we're also so focused on earlier age, you know, before sexual activity, when you can, you know, before they are exposed to HPV and infected.
Well, it was great and compelling data. And I mean, great for folks in this course to see how these issues have been looked at and studied and understood. And you mentioned Rwanda. I just wanted to also raise, we have a project there where there's been, we've been vaccinating HIV positive and HIV negative women as part of their antenatal care. Yeah. And because HIV positive women, as you mentioned, HIV, it's a serious HIV associated opportunistic illness that causes a lot of deaths. Right. Well,
and
thank
if you
you
can
again,
vaccinate
Jane.
them earlier, right? Like focus on, you know, you have, you know, that's where they're going to see the biggest impact and sort of, you know, reduce that sort of lifetime risk of cervical cancer.
Yes, the earlier the better.
Right.
Thank you so much for taking time out of what I know is a very, very busy time at the New York City Health Department these days to talk to the next generation of public health practitioners about vaccine preventable diseases. I really appreciate it.
Okay, thank you. Thank you for the opportunity.